so your gliclazide, glibenclamide, should only be, generally speaking, for your short term. Generally, you don't want to be using it long term. It's normally a rescue medicine like you would with your insulin, which is why it's used for symptomatic hypoglycemia, because a rescue medicine to get those blood sugars down, and then you want to be transitioning that patient across to something that's going to be more beneficial to them and be cardioprotective on that front. You can consider GLP-1 therapy where triple therapy is not effective, not tolerated, or contraindicated on that front. And then if you're finding that it's still not struggling with that, that's where you need to be referring for that specialist opinion, or for someone who's got a bit more of an interest and knows what's going on. There is advice here on the GLP-1 mimetic treatments, as well as renal considerations, a bit about pregnancy as well. And you've got all the different reference sources that are written down here as well. There is a specific separate guideline for frailty, which I'm not going to touch on today. But with that, I'm going to very kindly hand over to our lovely Mr. Jaffa and let him talk rather than me.
Thanks, Shanley. Good afternoon, everyone. Yeah, my name's Jaffa. I am a senior primary care pharmacist at the Southwest London ICB. And today we're just going to be giving you an update in terms of diabetes, really. So just to ask Chandni, should we ask questions at the end or should we ask throughout the presentation?
Whatever you prefer, up to you.
Okay, that's fine.
Do you want them? Do you want me to keep an eye on the chat and say them as we need to, or do you want me to go into it?
That's fine. Yeah, I don't mind throughout. To be fair, at least if we're still talking about a subject, we can discuss it.
Absolutely.
So just to go through the agenda, so what we're going to be talking about today is the GLP-1s, the stock shortages, and the updates in terms of formulary status in Southwest London for oral semaglutide, Rybelsus, and tirzepatide, which is Mounjaro. We're going to run through as well the our Southwest London diabetes blood glucose and ketone meters, testing strips, and Lancet's position statement, as well as why we recommend sitagliptin as the first-line DPP-4I. We're also going to quickly touch on the insulatard, Levemir, Inalett stock shortage and what the advice is, and as well as talking about the insulin pen and safety needles position statement that we have in Southwest London. I know it says at the end questions, but you can ask questions if you just put your hands up throughout the presentation, or if you write them in the chat, we can discuss it as well. So just to start off with, I know a lot of you are aware of the GLP-1 shortages. So in terms of the latest update, so on the 18th of March, when we were basically notified semaglutide, Ozempic, dulaglutide, Trulicity, and liraglutide, Victoza, there is still an ongoing shortage. And the advice for clinicians is that you should only be prescribing them for their licensed indication, and we should be reviewing patients to see, do they actually need the GLP-1? Do they still meet the criteria? Have they met the treatment goals as per NG28 NICE guidance? We also advise not doubling up lower doses where patients are on a higher dose preparation, not switching in terms of availability, and not to be prescribing more than 1 month's supply just to stop patients stockpiling unless there is a clear reason for you to prescribe more than 1 month. Where you have patients prescribed Victoza or Byetta, or you have patients that are unable to obtain Ozempic or Trulicity for 2 weeks or more, you should be considering prescribing Rybelsus, so that's the oral semaglutide, or Mounjaro, which is the tirzepatide, and just ensuring that the patient has like the appropriate needles, training, etc. With these two, there is stock, and the market currently can support prescribing. But we do need to check in terms of patients, do they have any intolerance to the excipients, and do they is it clinically appropriate? If you have situations where the patient can't have the Mounjaro or they can't have the oral Rybelsus, in that case, you'd need to refer and speak to a specialist. And just to touch on what the actual indication is for the GLP-1s, including the tirzepatide. So it's used for triple therapy with metformin and two other oral drugs, and two other oral drugs is not effective or not tolerated or contraindicated. In that case, you'd consider the triple therapy by switching one of the drugs for the GLP-1s in adults with a BMI of 35 or greater, adjusted for Black, Asian, or any other minority ethnic groups. And they have a specific psychological or medical problem associated with obesity, or they have a BMI that is lower than 35 and whom insulin therapy would have significant occupational implications, or where weight loss would benefit other significant obesity-related comorbidities. But what we do ask you to do is actually look at the patients that you've currently got on GLP-1s, and what we should be checking is, do they actually need the GLP-1s? So we need to be checking, have they had a reduction of at least 11 millimoles in HbA1c or 1%? Or a reduction of at least 3% initial body weight 6 months from starting the therapy. And if they don't meet the criteria, in that case, you'd need to stop it and refer to a specialist and see what the next option actually would be for that patient. So it might be a good idea before even considering switching a patient, just actually checking, is it clinically appropriate for them currently?
Absolutely. And you can imagine that's actually quite a difficult one. It's like kind of like the orlistat issue that we have, that you've got to make sure that they're losing weight consistently on that front. But it's really important that we do that with the GLP ones to make sure they actually are imperatively used and used correctly on that front. Jaffa, I don't know if you've heard about this, but apparently there's a quota restriction for community pharmacies to request and order Ribelsis. And one of the local pharmacies has said they can't fulfill all scripts and is requesting a letter to be sent to supply to request more stock to meet demand. Is there such a letter? This is the first I've
I
heard on
haven't
that
heard
front.
of it, but I can look into it, but it's not something that I've come across.
Yeah, if you could. I think the key thing is that if you're finding that there is such an restriction in place on that front with the local supplier, it may be a matter of just speaking to them. They may end up doing something a bit like what they did with EpiPens, where they ask you to scan across an
Mm,
anonymized script just so they can make sure they meet demand and just so that people aren't stockpiling on that front. But it's best just to speak to the supplier, because in terms of a letter, they may just require it in writing from yourself. But as far as I know, there isn't anything from Southwest London Post that we have to get this written out. But if you could look into that, Jaffa,
yeah,
that'd
yeah,
be
I can have a
amazing.
look into that.
Thank you. Sorry, I'll let you carry on.
Oh, no, no, it's okay. Next slide, please. So just to update you on our formulary, so if you have a look at our Southwest London formulary now, you can see for the oral semaglutide Rybelsus, it is green for type 2 diabetes as part of oral triple therapy without insulin. And basically, if the patient is on insulin, then it will be amber 2, because you'd need advice from a diabetes specialist team and you'd need ongoing consultant support. But what there also is you need to have up-to-date retinal screening indicating that there is absence of or mild or stable retinopathy. So if you do have a patient, for example, on a GLP-1 and you want to switch, you need to see if they are on insulin. If they're on insulin, in that case, you'd need to speak to their specialist or consultant. If they're not on insulin and they've got the retinal screening, then you can do it in primary care. And you can find the link on our Southwest London formulary, and it has, for example, our type 2 diabetes guidelines and the shortages. So the MSN link is also there. And just to also let you know, for the oral semaglutide, the Rybelsus, currently we are recommending it, but when the injectables and the stock shortage resolves, the oral treatment would then go back to being considered second line. But currently, the Rybelsus and the Mounjaro is what we're recommending.
And just to
Um,
give some context to that, that's
yeah,
because of the CV protection that the injectables will give you, significant CV protection compared to the oral side, because there's no CV protection as yet. We're told Novo Nordisk saying to me otherwise, that there is other information coming out potentially, but it hasn't come out yet. So because of that, the CV protection that comes through for peripheral vascular disease, for MI, stroke prevention on that front, is actually significant. So that's a clinical reason behind why we would be going back to those as first line rather than the oral treatment as well. But yeah, feel free to add on to the Jaffa. I just thought I'd just explain because I knew that was a
No,
question
thank you so much.
that's
That was
already come up in my phone saying, why do we give one over the other? So I thought, let me just answer it because I thought that was a nice bit just to jump in.
Thank you for that. Next slide, please. And it's similar for the tirzepatide Mounjaro. So it's green for patients without insulin, and it's amber 2 for type 2 diabetes patients in combination with insulin. So it's similar kind of guidance. And just to also let you know, it should not be prescribed for weight loss in primary care. There is going to be a nice TA and it's going to be licensed for weight loss, but then it's going to be similar to the GLP-1s in terms of that needs to be started by a specialist or T3 weight loss pathway. But we shouldn't be prescribing it for weight loss in primary care, and it should only be for diabetes. Next slide, please. And here you've got the suggested pathway for diabetic eye disease. And what you can do is have a look at the PCDS and the ABCD guidance. So when you've got patients who you are planning to start on Rybelsus or Mounjaro, then it might be useful just to have a look at that pathway and see what the appropriate advice is. So for example, if someone's got retinal screening done and they've got no diabetic retinopathy, then it's a case of actually just discussing with the person in terms of the risk of progression of eye disease with their current glucose control, emphasizing attending eye screening appointments, what the signs and symptoms are, and in terms of like signposting or referrals, and when to seek help, etc. But it also has useful guidance in terms of switching. So if you've got someone who is currently on a GLP-1 and you're switching to Mounjaro, in all cases, you'd need to start at 2.5 milligrams once weekly and titrate up. With Rybelsus, it's similar for all GLP-1s except the Ozempic. So if you've got someone who is on Ozempic 0.25 milligrams, you can start them on 7 milligrams once daily of the Rybelsus, or if they're on 0.5 or 1 milligram, then you can start them on 14 milligrams once daily. So you wouldn't need to titrate up from the lowest dose. And you can find more information on the PCDS and the ABCD guidance. Chani, I don't know if you've got any more information.
I was just going to add to that. So just be careful when you're looking at switching them. So starting at the 7 milligrams is fine. If you're going to the Ozempic, the actual SPC says that 7 milligrams is equivalent to the 0.5 of the Rybelsus. So just be careful with that. Although the ABCD's guidance says that, when you're doing the jump, what I would suggest is to start on the 7, even if you are intending to put them onto the 14, put them on the 7 initially, because otherwise they get a lot of GI effects because it's working directly on the lining of the stomach. So practically, if a person can't tolerate the 14, it's better to lower down the dose, start on the 7, and then up titrate to the 14, because otherwise people get a lot of GI effects. And I've had a lot of patients who have ended up feeling rather sick and feeling really unwell when they've gone straight to the 14. Although the propagation data is there that it should be working that way, it's better to be safer and let them start at the 7 and then increase up normally. So like you would if you were starting it from scratch and they were on nothing, you would start on 3 and up titrate to 7 after the first month. Maybe better to start at 7 practically and then increase up to 14 if indicating if patients are able to tolerate, just from a practical point of view for that patient, because otherwise I found in practice that people are really struggling with the side effects because it works directly on that lining of the stomach. But obviously the guidance is there, but it's just a practical point with patients is just probably makes more. She says as she ended up muting herself. Back to you, Jaffa.
Thank you, Chani. That was really useful. Next slide, please. So this is just a bit of a prescribing information. So just for oral Rybelsus, so the oral semaglutide, as previously mentioned, it is a GLP-1 receptor agonist. In terms of the dosing, so if you're starting someone newly on it, it's 3 milligrams once a day for 1 month, and then after 1 month, you increase them to 7 milligrams once a day. And then after at least 1 month with a dose of 7 milligrams once a day, the dose can be increased to a maintenance dose of 14 milligrams once a day to further improve glycemic control. In terms of monitoring, so it's the baseline HbA1c and weight, and then to review 3 to 6 monthly initially, in terms of HbA1c and what their weight is, and then that can be increased to 6 month intervals. And then just to review it as per NICE continuation criteria, as we mentioned on the first slide. So in terms of the reduction by 11 of HbA1c and the at least 3% body weight. Annual retinopathy screening as well in terms of monitoring. And then the other thing with it is in terms of administration, it's got quite specific instructions for patients. So they should be taking on an empty stomach, waiting at least 30 minutes before the first meal or drink of the day, or any other more oral medication. It should be swallowed whole with a sip of water, up to half a glass of water equivalent to 120 ml, not to split, crush, or chew the tablet. And then here's just a link for the patient printed information. So if you want to show it to patients in terms of the administration. In terms of Manjaro, tirzepatide, so it's a dual GIP GLP-1 receptor agonist. So it's got the dual effect. And in terms of dosing, it's 2.5 milligrams once a week for 4 weeks, to be increased to 5 milligrams once a week. If needed, dose increases can be made in 2.5 milligram increments after a minimum of 4 weeks on the current dose. The recommended maintenance doses are 5, 10, and 15, but the maximum is 15 milligrams once a week. In terms of monitoring, similar to the Rybelsus in terms of the HbA1c and the weight. And in terms of administration, it'll be similar to the injectable GLP-1s in terms of once a week at any time of the day, not to mix with insulin. And to inject under the skin, so it's a subcutaneous injection of the stomach, abdo, thigh, or upper arm. And there is a useful link from the manufacturers in terms of administration if you want to if you want to visually show a patient in terms of administration. And then just a few points as well. So not to prescribe semaglutide or tirzepatide for weight loss in primary care. One tirzepatide Manjaro pen contains 4 doses, so that's equivalent to 28 days supply. So just to be careful not to be prescribing 4 pens, assuming that's 1 month, because then that will mean that the patient will have excess stock. And just to refer to our formulary for more information in terms of the indication and the formulary status, which we've just discussed. Anything you want to
Just
add? Yeah.
just to add in there, sorry, there are some Manjaros out there that are single dose unit pens, so similar
Mm.
to the Trulicity. So we need to make sure that the pharmacy is that you're going to and are being prescribed are giving the right injection devices for that pen. So there are the pens, and there's a similar device to the Trulicity. So we just need to be careful with that to make sure patients are getting the right devices out there. They should be getting the pen to make life easier for everybody, but just to make sure that some of them do look a bit like Trulicity, so they may request 4 pens per thing. So it's going to be making sure you pick the right thing when you select it down on the drop down list on your eMIS or system one side. So it's not the single dose pen that you're prescribing.
Thank you. And yeah, has anyone got any questions so far about anything that we've discussed?
No questions as yet, don't worry. As they come
Yeah,
through, I'll ask them away, don't worry.
amazing. Thank you. Next slide, please. So this is just a question that I just want you all to have a go at, and if you can just type in the chat what answer you'd put in. But essentially, you've got a 55-year-old patient who's type 2 diabetic, taking a GLP-1 receptor agonist. It doesn't actually matter which one. For the past 6 months, at the start of their treatment, the HbA1c was 75 millimoles, and their weight was 95 kilograms. After 6 months of treatment, their HbA1c is now 67 millimoles and their weight is 93 kilograms. Based on NICE guidance and NG28, should treatment with the GLP-1 receptor be continued or discontinued? So in terms of the options, you've either got A, where you're continuing the treatment because HbA1c has decreased, B, where you're continuing it because there has been some weight loss, C, you're discontinuing it because HbA1c reduction is less than 11 and the weight is less than 3%, or D, discontinue the treatment because HbA1c reduction is less than 15 and the weight is less than 5. So I'll just give you a couple of minutes, just have a go, and then if you can just type in the chat which one you'd put in.
So we've got a C, coming through,
Mhm.
another C coming through. We've got another C coming through. She says. Another C coming through. I think we're getting a gist here.
I think
Another
so,
C
yeah.
coming through. I think you got your answer, Jaffa. I think everyone's going to be saying C. Oh, we've got one. B, as is patient directed. Yes, it's not always guidelines, and guidelines are a guide, is what I'm going to say. But okay, fine on that front. Another B on that front.
I think you've created a trend now with the bees.
How I roll. It's how I roll. I'm the diabetes specialist here. There's a reason that I am me. I think the key thing for me is you got to think about the patient in this, and has there been supply issues in the patient being able to get hold of the medication? Because not everything is black and white sometimes.
Mhm.
I've had patients who've had massive supply issues and haven't hit the target, so I've had to bear that in mind because they haven't been able to get hold of the drug and balance it out. But overall, I think we're getting more trends of C overall.
Um, Nish, is it right if you go to the next slide? Yeah, so according to the guidance, it would be C. And the reason why is because you'd only continue the GLP-1 if type 2 diabetes has had a beneficial metabolic response. So reduction of at least 11 millimoles in HbA1c or a weight of at least 3% of the initial body weight in 6 months. Does anyone have any questions about that?
So just to
Is
add to
anything you
that,
want
the
to add?
reason,
Yes.
so I just think I'd add to that, when you're looking at a patient with going and assess it, I've got someone who said 3% of 95 is 2.85 kilos. Patient has lost that much weight, but they've not reduced down. It's it's not an and or on that front. They have to have reduced their HbA1c by 11 millimoles as well, according to the guidance, as well, according to what guidelines are on that front. So I think it's important. Again, this is why I say it's important to weigh one up with the other on that front. Patient has lost 2 kilos, not quite 2.85, unfortunately. So this is where the guidelines can be a bit too strict. And I can see Hala smirking in the background. I think the key thing for me is has it had an impact? The reason that you should be checking in terms of a significant reduction on that front, which is a 1% equivalent to 11 millimole per mole, is because there are some patients who will have treatment failure with the GLP-1s no matter how much you ramp up the dose, because their natural receptors within the body don't actually work alongside that GLP-1. So there will be a cohort of patients who won't respond to the treatment simply, and you're giving them a treatment blindly, well, not blindly, but you're giving them a treatment that's not going to work because their own body's natural receptors won't work in that way. So it's a balancing act between that. It's kind of like giving someone an SU when their pancreas is completely maxed out. It's not going to work. It's treatment failure. So you need to make sure that you're doing what's right by that patient on that front. In this current day and age, with everything going on, I would normally go and have a bit of a gray area. And I probably shouldn't be saying this with the ICB on that front. I was sitting here on the call. If there's a significant HbA1c reduction on balance and it's just slightly off the weight, you can give them a bit more time and saying, actually, the guidance is this. However, if I'm not getting either or of those on that front and it's away from those, because again, there is a variation day to day of a kilo one way or the other because of water retention. You need to make sure you're balancing and following the guidelines on that front. They need to be getting that 11 millimole reduction, especially if it is significantly high at 75. Dropping down to 67 is great. And it also, I would be taking into account as well, have we up titrated that person to a correct optimal treatment dose? Because if, for example, that person is on Trulicity, which is 0.2 Trulicity, I've gone completely blank now because I haven't prescribed Trulicity for so long. If you're going and using the subtherapeutic dose on that front, then it's not going to work. So if you're looking at 0.75, there you go, it's come back now. I was going to give you the Ozempic dose. If you're using a 0.75, which is subtherapeutic and actually not going to give you a therapeutic reasoning on that dose, and not going to get you a dose of right introduction, I would be saying you'd give them longer on that 1.5 dose, which is a therapeutic dose. If you're not getting on therapeutic dose, you need to be careful about consuming prescribers. So you need to have good rationale as to why you are continuing that particular medication. I think that's how I would put it on that front. So it's looking and making sure therapeutically that person has been inclined and been given a good enough chance, especially where stock hasn't been available and people have been on and off it backwards and forwards. I think that's something we need to bear in mind as well. And that's something I've been struggling with probably the whole way through January through to March on that front. So it's a balancing act currently when you're reviewing them. But absolutely, if a person's not reducing it down by 11 millimole per mole, you probably are finding that they may not be, maybe a potential non-responder to a certain degree. So I'd be looking at the dose and I'd be looking at what's appropriate for that patient. Back to you, Jeffa.
Thank you so much. Next slide, please.
And this is why Marvin said, when it comes to the clinical stuff, I'll bail you out on that
I
front
know,
because
that's
I'll
why
just jump in.
I'm really happy that you're here. So just moving on to the diabetes blood glucose ketone meters, testing strips, and Lancet's position statement. So the actual recommendation initially came from NHS England, but we've developed our own Southwest London local policy, which takes into account all the information from the NHS England guidance. The main objectives of the guidance is to ensure that there's equitable access for all patients, having minimum quality standards and aligning prescribing practices across Southwest London, as well as optimizing the resources that we have in the NHS. The only variation that we have from the NHS guidance is that we've added the instant meter. And the reason that we've done that is because there is a local pediatric preference. So the consultants prefer it, the CNS nurses prefer it. And we've just had overall very good positive feedback from them. And also it's cost effective, so it's not more expensive than the recommended meters that we have, and that's why it has been added. Next slide, please. So in terms of the guidance that we have for clinicians, so for type 1 diabetics, continuous glucose monitoring, so CGM, is recommended. However, patients still need capillary blood glucose measurements. For type 2 diabetics, just to assess the need for self-monitoring in line with the NICE guidance. For new users, just to have a look at our Southwest London policies and to supply the suitable meter that we've listed on the policy, and to ensure that the patient has received adequate training. So in terms of correct usage, storage, and how to interpret the readings. For existing users, firstly, to assess the need for self-monitoring, do they need to continue doing monitoring, and removing the non-preferred meter from stock after having a discussion with the patient, and to supply the suitable meter that is listed. In terms of removing non-preferred meters, you can check with the manufacturers. Some of them have like a recycling scheme where you can send it back to them. But it's just a case of checking with the manufacturer. Next slide, please. In terms of choosing a meter for your patient, this is based on their needs and the functionality that comes with each meters. And some of the factors are included are connectivity, the warnings that they provide, any alerts, the display size, the size of the actual meter itself, and what cohort they meet. And that I can show you on the next slide. But essentially, if you have a patient and they can technically get multiple meters based on our guidance, then the option that you choose is the one that uses blood glucose testing strips with the lowest acquisition cost. So if you have a look at our guidance and you think, oh, there's 2 or 3 meters that I can choose, then choose the one that has the cheapest, essentially, blood glucose testing strips. Next slide, please. So you can see here, we've got the table on our policy, and essentially you've got all the different cohorts of patients that you could be prescribing or supplying meters. So you've got, for example, your type 1 diabetics or ketosis prone type 2 diabetic patients, and you've got the meters that are recommended, and for patients that need additional functionality, you've got the meters that's recommended there. And you can see at the bottom, we've got our local Southwest London meter option. And that's for the pediatric patients, essentially. And that's the one that we've added as like an extra from the NHS England one. You can find this on our position statement on the Southwest London IMO website. If you need more information in terms of the functionality or more information about each meter or how to order the meters, etc., all of that you can find on the NHS England guidance, which the Southwest London local policy actually refers you to as well. So if you have a look at the Southwest London one and you have any further questions, then you can click and have a look at the NHS England one. And that can help in terms of like if you have a patient and you want to explore the different functionalities for each meter. Anything you want to add, Chanti?
So a question that's come
Yeah.
through to me by text because they didn't want to put it in the chat for some reason. So this is normal for me. I always get bombarded by text for some reason. So question for you. So there's obviously a lot of different meters, and across the different boroughs, there's always been a different preference for different meters. Now, what do we do? Obviously, if some of our meters are on there and some of our meters aren't on there, where do we go and with this on that front? And how do we know which one to choose?
So if you're currently using a meter that's listed on the table here, then
Hmm.
it's okay. You can continue to use it. You don't want to change it based on blood glucose testing strip costs. If as long as it's actually listed on there, then it's fine. But if you've got one that's actually not listed on there and it's not recommended locally and nationally, in that case, it's a case of removing it and looking at the options that we have now and maybe choosing one or two options to just keep at the practice or whatever clinical setting you're at, and then just continue using that. So that's our guidance essentially. But it's just making
There's no preference by borough anymore, like they used to be, that we used to use one over another and a different borough would use another one. Like for example, when I had people coming out of George's, they'd come out with Wave Sense Jazz. When they came out of Kingston, they
mm,
came out with Gluco RX. So there's no preference now
there's no
over one over
preference,
the
but
other.
just as long as they're using the preferred ones.
Perfect. That
Yeah.
hopefully answers the question. Thank you. And I think Marvin very kindly has popped the link in the chat so for everyone to, because I've actually asked him for this same thing as well before. I was like, I need this list now. Bless him. And he had no choice but to pass it on to me.
Thanks,
But
Marvin.
there you go. There you go. I'll let you carry on.
Perfect. Next slide, please. Just to run through as well, so sitagliptin is our Southwest London preferred gliptin, so DPP4 inhibitor. And if you have two drugs in the same class and they're both appropriate for a patient, then the drug that you choose is the one with the lowest acquisition costs. So for us, sitagliptin, the generic, is the most cost-effective gliptin and is the first-line option for eligible patients. So the actions for healthcare professionals that we do advise is for patients that are newly starting on a gliptin to consider it as your preferred choice. If you have a patient who is on an alternative gliptin, then consider changing that to sitagliptin if it is clinically appropriate. To review ongoing prescribing if continuation criteria has not been met, and to ensure optimization of therapy for management of diabetes. So as a first line option before you even consider switching to another gliptin, you want to see is gliptin actually the right choice for the patient and have they met the continuation criteria in terms of HbA1c. Ensure that patients who are changed from an alternative gliptin have their HbA1c rechecked 3 to 6 months after switching to sitagliptin. Linagliptin is recommended as a second choice after the patient has tried sitagliptin, and to also make sure that patients are being informed of any changes that is happening to their therapy. The safety points to consider when you're prescribing sitagliptin is that the dose of sitagliptin is 100 milligrams once a day whenever renal function is greater than 45 mils per minute. And sitagliptin is licensed for use in patients with renal impairment and can be safely prescribed where renal function is stable and non-fluctuating. Dose adjustments are recommended, and the table you can see below actually shows you the dose equivalence of changing to sitagliptin and in terms of renal function. So for example, if you have someone on allogliptin 12.5 and they've got a renal function of, let's say, 35 mils per minute, then and if their renal function is stable on 35 mils per minute, so it's not fluctuating, then you can change them to, for example, sitagliptin 50 milligrams once a day. And the reason why it is recommended is because, like I said, it's the most cost effective, and you can see the impact of that on the table on the bottom right. So, for example, if you have a patient on linagliptin, let's say 5 milligrams once a day, and you switch them to sitagliptin 25 milligrams once a day, then that's an annual saving of £362.40 per patient. So if you have like a huge number of patients, you can only imagine how much money we can actually save from switching the patients to sitagliptin. So it's a case of maybe just doing a search at your practices and identifying the patients who are, for example, on alogliptin or linagliptin. firstly checking should they actually continue on the gliptin in terms of continuation criteria, and then just having a look at are they stable, is their renal function stable, and then maybe consider switching them to a sitagliptin if clinically appropriate. Anything you want to add, Sandy?
I think you've covered it all beautifully, so I don't think I need to
Thank you
add
so
anything to
much.
that at all.
Thank you. Next slide, please. Just a question again to test everyone. So you've got a 70-year-old patient with type 2 diabetes. They've been taking allogliptin 6.25 milligrams once a day for the past year. Their renal function is 18 mils per minute, and the 18 mils per minute is not fluctuating, so it is stable. The HbA1c is also stable. Which of the following actions would be considered the most appropriate based on the patient's condition and updated guidance? And for this question, just assume that the patient's HbA1c has reduced, so don't worry about the continuation criteria. But essentially, do you continue with the allogliptin as any change in medication might destabilize the well-controlled HbA1c? Do you change to sitagliptin at a reduced dose of 25 once a day, considering the renal impairment and cost effectiveness? Do you switch to linagliptin as it's preferred for patients with severe renal impairment? Do you change to sitagliptin as its first line gliptin with a lower acquisition cost? Or do you consider adding a different diabetes medication to further support HbA1c control and maintain the allogliptin therapy? Again, if you can just type it into the chat, and we can just have a look at the trends.
That would be it. It's an amazing, actually interesting question, but I'm actually going to add in as a bit of a mix here. What is it? You said HbA1c is stable. How stable and what number are we thinking? Do we have a number? Because that's
Don't have a
going to be
number.
dependent on what we're thinking. Because actually, if I had someone who's 48, just putting it out there as devil's advocate, if I had 40, I'd probably just stop it altogether because there's no indication for it if it's that well controlled. It's not going to be in CV benefit or anything like that. If you've got someone who we just need to nudge down below, because again, and when we look at the DPP4s, they only tend to nudge your HbA1c down by about 3 or 4 millimole per mole overall. So we're just nudging it down effectively. So if it were just nudging it down below that kind of number of, say, we want her target to be 58 and it was 62 and it's nudged down to say 58, 57, maybe we need to keep it going on that front. So I think it's a balancing act on that front. So I think it's a balancing act. So what do people think they're going to do? I've had a question for you while they're answering. What do we tell a patient in terms of sitagliptin preference and is regards to? Because it's great that ICB have come out with it. That is a cost-effective kind of side. Do we tell them it's cost-effective and that's why the ICB have chosen it?
And we can talk about it in terms of like, firstly, efficacy. So it would have similar efficacy, and also the fact that you want to have equitable access for patients. So all patients now we're recommending to be started on sitagliptin. So if it's got similar efficacy and it's cost effective and all patients are recommending it, then it's just a case of just explaining that to a patient, and basically explaining in terms of like the fact that it's got similar efficacy would mean that it shouldn't have that much impact on their HbA1c. But I don't know if there's anything else you would add, but that's how I would look at it.
So Manjeet very kindly has written in, obviously it's a NICE stance. So we want to be kind of going with what NICE is saying. We will all still have patients who for some reason or another are still on Simva 40 when they should be on a Torva 20. Those patients never go away and they are still there. And I know I can imagine Hala has a few of those as well because we all have those patients somewhere. I love how no one is answering this question and no one's put anything in the chat as to what they're going to do. So this is going to be all down to you. But I think it's a balancing act on that front that you need to go and think about what's going on that front. And I think our lovely Marvin has put in, personally, I was shy away from the fact that it's NHS value for money and that it can be better spent elsewhere. In fact, NICE says it is the most cost-effective option, and the fact that it says it's first line, and that's what I tend to drive for. So I'm glad that Marvin said it. He said it in a more eloquent way than I probably would say it. But the fact that it is first line by NICE, and NICE tends to say to go align with it first, like we would with driving a torvastatin, we say it's the first line based on what NICE tend to suggest is how I would suggest it. There's always going to be a population of patients who can tolerate, who can't tolerate. There are going to be medicines that work one way and the other, but again, it's that brother or sister drug. So where someone can't go and take, for example, dapagliflozin, they can tolerate empagliflozin. It's just what drugs work different ways, but it shouldn't have an effect on the efficacy. It should be one of those things that works alongside and still go and continue to give you that control, but again, is able to tailor the dose better for you. And I also say that actually sitagliptin is probably easier, more readily available compared to alogliptin, which isn't prescribed as regularly, which is what I found in my personal opinion along the way. So I tend to find that people generally can get hold of sitagliptin easier than alogliptin. So for that reason, it tends to be easier on that front. So we've got answers coming in
We
finally after
do.
that big slur of me going explaining, and we've got a lot of B's coming through. B's and a smiley funny upside down face. So there you go. Go on, Jaffa. Where are you going?
Next slide, please. Yeah, so the answer is actually B, and that's to change the sitagliptin at a reduced dose of 25 once daily, considering the renal impairment and the cost effectiveness. And the reason why it's 25 milligrams once a day is because if you have a look, the renal function is 18 mils per minute, and as recommended by the SPC, really, you can see that the recommended sitagliptin is 25 milligrams once a day.
The one
Next,
thing I will
yes.
say, and just to put it out there, is that have we done some engagement with the hospitals? Because they're very quick to put everyone on linagliptin when they come out of the hospital, because it's just the one dose, it stays the same, and that's the way it is. Have we done some engagement with our colleagues in the secondary care about this?
I don't know too much into depth about it, but from what I'm aware, Manjeet has actually spoken to the acute trusts and the consultants in terms of the sitagliptin. Correct me if I'm wrong,
And
Manjeet,
I'm
but
sure Marvin probably would have at some
Yeah,
point as well.
yeah,
I'm happy to come in. Thanks,
thank you.
Jaffa. So the acute trusts were engaged in this process to
Amazing.
have sitagliptin as our preferred agent of choice, and we're on board with that from the clinical perspective and cost-effective perspective as well. And we're just about to do some more comms with the acute trust as a reminder to make sure that actually patients are started on sitagliptin initially, so that it's less of a headache for it to come out to primary care, for them to then have those conversations with the patients.
Thank
So
you, Manjeet. Thank you
partly
so,
there's
so
probably a
much.
bit more to do with that.
Thank you so
Thank
much. I
you.
think that's the big thing, I think, on that front, when we go and have that pushback, because again, you do see certain clinicians who do that. And I think that's also in our lovely chat as well, that someone did a joint clinic with a DSN and she recommended linagliptin instead of sitagliptin due to needing Usinese in 3 months. But initiated sitagliptin, will monitor in 3 months' time. Ronnie is now doing, from St. George's, doing sitagliptin where he would need to. The other thing I'd probably say is where you've got trusts like Chambers and Kingston, for example, or you've got that kind of tertiary care service or the tier 3 service, probably need to have a bit of a chat with them as well, which I'm sure we are doing already, just because there are a couple of recommendations filtering through still for the different ones that are out there. I think I'm sure we'll end up being all completely on top of it, but I think it's just one of those things that it's just going to take a bit of time to get on top of.
Thank you. Next slide, please. So just to give an update in terms of the stock shortages, so there is an ongoing, well, not stock shortage in terms of this one, in terms of discontinuation. So you've got the Insulatard Inhalet, the pre-filled pen, and the Levemir Inhalet pre-filled pen. So in terms of the MSN, it says discontinuation for 31st of May 2024, so end of the month. And the advice that is provided is not to initiate any patients on Insulatard Inhalet or the Levemir, to identify and review patients currently prescribed on them. So maybe doing a search on EMIS. And for patients that are on Insulatard, to consider prescribing Humulin I KwikPen where appropriate. And then the MSN has further supporting information when you are considering to prescribe. And in terms of the Levemir, to consider prescribing the Flex Pen or the pen fill cartridges where appropriate. So if you are considering prescribing the Levemir pen-filled cartridges, ensure that the patient is prescribed a Novo Nordisk insulin delivery system, and also Southwest London preferred pen needles, which I'll actually go on to in a couple of slides. Just to also let you know, the pen needles have a universal fit on all leading insulin pen delivery devices.
I still
When you're
remember the
yeah.
days when we used to go and think that those pen needles won't fit on my device and won't fit on that pen. They all fit universally. So please
Yeah.
be aware of that. So yes.
And sometimes, because the manufacturers still say designed for blah 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 flex pen, but it doesn't mean that you can't use it. It's like you said, it's still universal. When considering alternatives, take into account patients' dexterity, vision, ability to use the new device, and whether support is needed when administering the dose, and to also seek advice from specialist diabetes teams on management options if the options above are not considered suitable. For prescribers and pharmacies, to ensure that all patients initiated are counseled, given the appropriate needles, training, and also signposting to any training videos that are available, and also advised if blood glucose levels need additional monitoring, the patient should be notified of that as well. Anything you want to add?
So generally speaking, this is the clinical bit. Generally speaking, when you transition from one insulin to another, as a rule of thumb, you always would reduce down their patient's insulin dose initially by 10 to 20%. If they're going from one insulin to another, just in case they would end up having any hypo episodes because of slight change, because they're not exactly bioequivalent. However, you would do that, but you would very quickly up titrate that dose by 2 units per dose per day, every 3 days, or 2 to 3 days rather, ensuring that they're not having hypos. That's generally, as a rule of thumb, what you would do, switching between one to the other, just because there's no direct bioequivalence between the Humulin and the Insulatard Inhalet, for example. That's what I've been doing in practice. So it's good for that person also, because of one's the dial and one is obviously the pen. We need to make sure that the patient knows how to use it and is able to utilize that, because of they are two different mechanisms and ways to deliver that. So it's just making sure that they are aware of that. You can very quickly ramp up the dose on that front, but as a port of safety, if they've had hypos, probably 20%. If not, then 10%, but rapidly increase up that dose in itself. But do please get your diabetes teams involved as well, because they'll be the best persons to be able to counsel on that front.
Perfect, thank you. Next slide, please. Just to quickly touch on the pen and safety needles. So we have released a Southwest London position statement that you can find on our IMO website, and the link is also there at the bottom. But essentially, for pen needles, Southwest London recommends the use of pen needles costing less than £3 per 100 needles. For safety needles, it's a recommendation of like less than £13 per 100 needles where clinically appropriate. The rationale for it is that pen needles are available in a range of sizes from 4mm to 12mm. All needles have a universal fit on all leading insulin pen delivery devices, and the needles conform to the latest pen needle standards. The guidance that we have for clinicians is to prescribe by brand. No new initiation of high-cost needles. So by high cost, I mean pen needles greater than £3 or safety needles greater than £13. To review existing patients and to switch to the preferred options. Patients using longer needles, for example, the 8mm or the 12mm, to review and change to shorter needle lengths, so less than 6mm or equal to. And if you need any further details or guidance, it's a case of having a look at our position statement, which you can find on the IMO website. And next slide, please. And this is just this is just taken from our position statements in terms of the preferred needles that we have. So you can see it's listed which ones are recommended, which ones are preferred, etc., and all the different sizes that they come. And it's the same for the safety needles. So for example, we've got the Microdot or the Gluco RX. Any questions or anything you want to add, Jana?
No, I think that's spot on. You'll probably find that your script switch is probably coming in already with the IncyPen. I've seen that already coming through, to be fair. The only other thing I would say is that just be careful with stock availability. So the GlucoRx safety pens were unavailable. I think when these came through, so the safety pen needles actually went out of stock for a little while. So just be careful, and especially for those patients who've got carers who need to administer insulin things. We just need to be careful with that. But as far as I'm aware, they did come back. But there are intermittent supply coming in and out from what we're seeing locally in local pharmacies across South West London. So just be aware of that.
Thank you. Anyone else have any questions?
Nothing in the chat. Otherwise,
No.
I frame it like I'm asking it. Don't worry.
Thank you. Next slide, please. Oh, it's any questions? Yeah, does anyone have any questions about anything that we've covered in the presentation?
So we've got basically ensure that the reason for safety needle is being documented is a comment that's been made in this. Absolutely, especially if you've got a carer, you've got a nursing home who potentially need to go and do it. You do need to basically document. And Manjeet, do you want to jump in on that one?
Yeah, sure. I think this has come about recently because in Sutton we just did a quick baseline sort of audit to see what's happening with safety needles and prescribing, and we found out of 79 patients that were on a safety needle, about 14 of them had no documented reason why they needed a safety needle. It was not obvious they had a carer or a third party administering, so it just made it a bit more uncomfortable as to why are we using a safety needle when there are cost-effective preferred non-safety needle products available. So there's that issue really, and we did find actually some of the patients can self-administer and there was no clear reason why they needed a safety needle anyway. So again, to explore those reasons. And then obviously third party administration is another discussion and a wider discussion as to who should supply the needles in those instances.
That's a question that I was going to have in terms of district nurses, because that's always an area for contention of who should be supplying them, because the district nurse is saying we should be prescribing them.
Yes, so I mean, ideally that should come under the organisation that covers those district nurses, because it's for the protection of their staff to administer to those patients. But historically, the GPs have taken on that prescribing, so this is why I think there's wider discussion to be had. There is, I think it's the Healthcare and Safety Directive that governs about the use of safety devices for their own staff for safe administration of medicines. So like I said, that's another bigger issue at some point to address and not quite a priority at this stage. And then in addition, where a safety needle is required, like Jaffa said, we have got preferred products on the position statement. A lot of our prescribing is for a BD product, which is non-preferred
as well.
Yeah. However, we don't want patients just to be switched from one to another, because I think there's that training, counselling. The carers need to be aware of how to use them as well. I don't think it's like for like changes for that. So that's why I wanted to make sure add that point in. Thank you.
Amazing. Thank you so much, Manjit. And actually saying that, I've used all of them one way or another. I used to administer my dad's insulin because that was what I did. And I did need safety needles and I had to explain that to the GP and they very happily prescribed them. There's not that much of a difference in they actually use them once they get used to it. It's a slight difference, but it's not that much of a difference. And once you get used to it, for patients struggling, there are lots of tips, tricks and techniques to be able to get them swapped across on that front from someone who's done it. So if anyone needs any support on that, I'm more than happy to always jump in on that front and to support if needed. Amazing. Well, thank you so much, Manjit, and thank you so much, Jaffa. That was really informative and really helpful on that front. Are there any questions before I ask them? Then they can love us and leave us on that front, or they can stay if they want. They're more than welcome to stay on that front. I'm not seeing any questions currently as we sit here. If you want to talk to us, you could talk to us and put your hand up now that the presentation's over, or feel free to pop it in the chat. I'll check my phone, make sure there's no messages on there either, because that's always one that comes through. No, nothing as yet. So I think we are good on that front. So thank you so much, Jaffa. Thank you so much, Manjit. I think that was really helpful.
Thank you for your clinical Actually, I learned a lot from what you were saying.
Nah, don't be silly. It's a joy of being a specialist on that front, she says, and being on too many boards of this, that, the other, and trying to help with too many things. But always happy to help, always happy to support if we need to on that front. But thank you so much. And following on from that, we've got a few people saying great session. So that's great to hear on that front. That's what we want to be hearing. But all the guidance, all of that is available, and we will get, we have got Jaffa's slides, which you'll very happily let us go and circulate to everybody, so
Yeah.
that everyone can have a copy of those slides as well going forward, to support you guys in your practice as well, to make life a bit easier going forward, because it's not as easy. I will see separately from the forum if I can get some education out for the tinzaparide, because I don't think people know enough about it when it comes down to it. So I think we'll try and sort that out separately as well, because I don't think there's going to be people who are aware about when to use it, how to use it, and so on and so forth. So I'll try and do that separately. And lots of well dones and good, very clear. Thank you. Very good session. So very happy campus on that front, she says. I'm going to go back to our lovely Menti, she says. And I've just realized the Menti's not going to work because I need it to do what I need it to do first. Can you please be nice on that front? Oh, very helpful, Menti. If you would work, I would be happy. And it's coming. It's coming. Why does IT always fail us when we need it to work? I don't know. It's one of those things. It never seems to do what we want it to do on that front. So I'll pop this under here and present and share, she says. So if we can please go on to
Tanya, we can't see the Menti slides.
I haven't got it yet. I haven't got it up yet, woman.
Okay.
Honestly, what do you make me of me, honestly? So if we can get everyone to go back onto our Menti on that front, and please respond. How did you find that session for the diabetes update? Was it good? Was it bad? Was it ugly? Hopefully not. Was it helpful? Was there anything else? Was it a bit too much information? Again, if you found that it's timed out, if you refresh the slide, refresh the questions, and then go and actually add it on, they'll then give you the option of going to do it, because it does time out after a while. But if you refresh it and then add your option in, if you haven't joined Menti, if you could join us on menti.com on that front with the code 39502866 on that front, that would be great. On that front, we've got a couple of people who would like a few more sessions, which is absolutely fine. Always happy to do more sessions on diabetes if we need to. But a vast majority of people have said that it was just right, which is great on that front. So it makes life a bit easier. But we will try and do more sessions if we need to on that front, to try and make life a little bit easier across the board if we can, because it's all about trying to make life easy where possible. I'm going to move my lovely Nisha up there so I can still see the timer on that front. So I think it's important that we go and try and cover vast majority of the bits and bobs, but I think it's important. And what we've done is, because I was told that the case studies were very helpful for everybody last time, I've done a couple of case studies for diabetes this time, so we can go and do that before we carry on with the rest of the bits and bobs that are there as well. So then it makes it easier. Again, if you're in the gallery, there's 40 odd of you there. Can you please jump on to Menti, give us some feedback? Use code 39502866. I do sound like I'm from Eurovision, but that's okay. That's a whole different story, which we're not going to talk about. And just give us some feedback on how you felt the session went on that front. So Jaffa, I think you did fab on that front, because I think the session went really, really well overall.
Thank you so much.
So that is closing as of now. A personal question, because I think it's important to ask. Don't worry, it's not about what are you sending me for my wedding present, because I think that would be a bit too much. But if we can go and just say, would people prefer a WhatsApp group, a Telegram group, or you don't mind on that front? Because then it makes it easier for us to be able to navigate what group to set up, because we've got a Telegram group at the moment, but conscious that everyone seems to be using different medias. If it makes it easier, we may be able to set up a WhatsApp group and then hopefully go and make it a bit easier going forward. Hala, I think we're seeing what's going on, and I think we're creating a WhatsApp group, which I can create. That's not an issue at all if we need to on that front. But I can create a WhatsApp group if that's what we need. I know people are like, oh my God, another WhatsApp group, but again, it will make it easier, hopefully, for people to then get the conversation going on that front. And to have all your South West London colleagues all together on that front, because I can aware that I don't tend to have other apps that can be a bit frustrating going forward. So you've got another 5 odd seconds. Get your votes in if you can on that front. Get your votes in and make your life easy, or make my life easier. So I think we might be also transitioning to the WhatsApp group on that front. But that is, for now, the end of my Menti. We'll come back to that a bit later. So the next part was a case study or two about what we've just gone through as part of the supervision side. So can you see my slides, Nish?
Yes, I can.
Perfect. Makes life easier. So we're going to do a case study basically on what we've just gone through on that front, so that we can then hopefully put it into practice. I'm going to need a chair. So Hala or Nish, if you could please give me someone shouting out in the background about what we found on that front. So we've got a case study for SM, who's a 56-year-old Caucasian on that front, was diagnosed with diabetes 12 months ago on that front, and is a 56-year-old office manager diagnosed about 12 months ago, routine screen. His grandfather died at the age of 50. Father's had a heart attack. He lives with his wife, is a social drinker, approximately 3 or 4 pints as a minimum when he sits down and has a drink, but otherwise tends to take it in as he goes on that front. In terms of kind of supporting evidence, his retinal screen is normal. His foot check is normal. He's got new onset microalbuminuria, but he's asymptomatic. He's a non-smoker. He does have ED, or he's complained about it in the past. Most recent HbA1c is 77, so about 9.2. His BP is 165 over 100. His LDL is 3 millimeters per litre, or millimole per litre, sorry, and he is treated to target that 40% reduction, which is great. His BMI is 33, EGFR is 62, and ACR is 10. On that front, he's currently on Atorva 20, so he's not on that simvastatin crew that we have that's still out there. He's on max tolerated dose of 1 gram twice a day of metformin, and he's on Ramipril 5. What are we going to do with Mr. SM? So let me know what you think, and pop it in the chat to let me know what you're thinking. Or talk to me, whichever you prefer. So in line with our South West London guidelines and the update we've just had, what are we going to do?
Johnny, okay, we've got some answers, and please forgive me if I don't pronounce these things properly.
We love you, Nisha, don't worry.
So add SGL T2,
T2,
increase Ramipril, Ramipril to max tolerated dose.
Yep.
Increase Ramipril.
Okay. I'm going to add into the mix. He's on, that's the max tolerated dose. I didn't write that in there. Max tolerated dose of Ramipril is that for him. Sorry. He couldn't tolerate any more. Well, maybe we should get Hala to go and do some talking. Save you having to worry about the talking, speaking of it.
Her mic's not working, Johnny.
Oh no, Hala. It's okay. It's okay. We get to see a beautiful face. That's the main thing.
Get better BP control, BP
Absolutely.
raised. So add second agent for HTN.
Hypertension. Yep. Okay. Shall I go on?
Yep.
Let's go on. So for SM, is noted to be very high risk of cardiovascular disease. So again, break it down exactly why we're doing what we're doing. Noted to be only on monotherapy, so individualized target for me, 48 to 53. Lifestyle advice, because we all went straight to the drugs, but we didn't think the guy smokes, he's overweight, he drinks a lot. We need to give him that lifestyle advice and make sure we're reducing that down and make sure we're giving that advice, because people can reverse their diabetes if they're early on, and that within that first 12 to 24 months, they can reverse their diabetes by direct. If we look at the direct trial, people can reverse their diabetes and go into remission. So try and give him that lifestyle advice and coach him through that. Don't worry, we're not going to do that, but absolutely blood pressure optimization. So we added in a calcium channel blocker for him of amlodipine 5 milligrams. And because his HbA1c at the moment was up in the 70s and was getting some osmotic symptoms, we wanted to nudge it down. So I started him on the gliclazide 80 milligrams twice a day, just to nudge it down on that front for the first 4 to 6 weeks. Rechecked his HbA1c and blood pressure to reduce it down. And is at that 4-week period, he reduced down to 60 millimoles per mole and 125 by 76. Reduced down his glucoside to once daily, and at that point added in the SGLT2 because he was getting some of those horrible osmotic symptoms coming through. So added in the dapagliflozin even for primary prevention, because the evidence says DAPA is better for primary, EMPA is better for secondary, and for those older, more mature patients. And this guy's pretty young still. Counseled the guy on importance of hydration, UTIs, DKA symptoms, Fournier's gangrene, sick day rules, and side effects. Repeated his HbA1c again in 3 months. HbA1c came right down to 50, and his ACR repeated as well, which was down to 0.1. Stopped his glucoside altogether and carried on the metformin and the SGLT2 altogether. Now, the reason that I went and started him on glucoside is because he had the osmotic symptoms, which again was on the screen, that he had osmotic symptoms, that he's feeling more thirsty. So for that reason, it's about going and making sure we're taking it step by step and going through. I hope I wrote he was thirsty on that front, but he was thirsty on that front. So he wanted to clear his osmotic symptoms first and foremost before we nudge it down and add in that dapagliflozin going forward. Same patient, funnily enough, but now we've gone down line. It's now 60 years old. So did really well with his diabetes, but seen a couple of other people in between on that front. As now we fast forward about 4 years down the line, he's now retired, 60 years old. I wish I could retire at 60. That'd be great. But now had diabetes for 5 years on that front. Again, same history on that front. And he stopped alcohol after his last intervention that he had with you, where he's gone and had that conversation on that front. He's a non-smoker now completely, well, an ex-smoker, I should say, on that front. So he's not smoking on that front. HbA1c has rocketed up to 85 on that front. His blood pressure well controlled at 125/85. LDL is at 2.5, so it's gone down even more, which is great. BMI's gone up to 35, and EGFR's dipped a little bit down now to 55 as well. He's got negligible ACR, so at 0.3, which is great on that front. And he's on the max tolerated dose of that. I should say he's also on the amlodipine as well, so I'll add that back in because I didn't write that in. But he's on the Ramipril 5 milligrams. He's on DAPA, and someone's whacked in sitagliptin in between as well. So we've already put him on to that third agent that we would be looking at, to going and adding him into sitagliptin on that front. What do we do now? So new patient, high HbA1c of 85 on that front, and is going a bit pear-shaped.
Johnny, we've got one. Since retirement, has he been keeping active diet and exercise? And then another one, check diet and lifestyle.
Big difference, big thing we need to be talking about for this patient on that front. And the other thing I'm also going to chuck into the mix is that when he had the gliclazide, when he was on that once daily, he had a hypo on that front, just one, but he had that hypo, so he was quite keen to get off it on that front. So he's not overtly keen on going back on that SU if he can avoid it. And his weight is 35 as well. So think about the side effects of these lovely drugs. What are we going to be thinking?
Check medication compliance, change SITA to GLP-1.
Absolutely.
And another one, GLP-1.
Absolutely. I'm glad people have been listening. So Jaffa did a great job in getting people to listen. I might have added a little bit. But again, first thing, like a lot of you said, lifestyle advice, weight loss, alcohol cessation, which we've already covered, but the exercise again on that front, because it's never too late to go and tell him. But again, because now he's on 3 different therapies, the target has now loosened up a bit to 53 to 58. So we want to making sure we're doing that. Blood pressure was optimal, optimization was optimal. So we don't need to action that at all. We've got the gliclazide, but generally remember, your gliclazide is your rescue medicine, so short-term use only on that front. Your DPP-4 sitagliptin, is it actually doing anything? Again, tends to dump it down by about 3-4 millimole per mole, up to about 5 sometimes if we're lucky. Ribelsis, do we go oral? Do we go the injectable because of CV protection, or do we go down the NPH insulin on that front? Because we're running out of options these days on that front, and we can't start anyone on GLP-1 injections, which is really annoying. But with this guy, I did stop acetagliptin, and because he's had no history of gallbladder disease, pancreatitis, diabetic nephropathy, or thyroid cancers on that front, we went down the option of Ribelsis. And because he's a new patient, we started him on 3 milligrams for the first 30 days. Then you increase him up to 7 milligrams once daily for further 2 months and recheck his HbA1c. And just as obviously was said in the talk, needs to be taken by mouth on an empty stomach when you first wake up with a sip of plain water with no more than 120 ml. That's equivalent, I think, 4 ounces of water, if I remember correctly. No spitting, crushing, or chewing of it. It needs to be swallowed whole. So anyone who needs it covertly or anything like that should not be given this way. Anyone who hasn't got capacity and is potentially going to chew those medicines can't give it that way. Or anyone through a peg feed should not be given it this way either. After 30 minutes, you can eat, drink normally and take your other medicines. So it'd be similar as you would, for example, with your levothyroxines on that front. So you'd want to have the same sort of process on that front with this as well. If you miss a dose of Ribelsis, you make sure you skip that missed dose and you go back to your regular schedule and start it again the next day. As ever, he's still on that SGLT2, so we want to make sure that the man is going into taking it and he's not getting any sick day rules issues, Fournier's gangrene, he's up front. I say this, and I had a patient yesterday came with a rash for SGLT2, which was a whole different story. Really important that we make sure that anyone we're starting on Ribelsis or any of the others, GLP-1 kind of sides, or even the tezapride, that you're telling them if there's any severe abdominal pain or vomiting that's occurring, to stop the medication and seek medical advice. And I'd be adding this into one of the sick day rules as well. Repeated this person's HbA1c, came down to 68 at 7 milligrams. Good. So carried on with the metformin, SGLT2 and GLP-1 and increased it up to 14 milligrams overall. Repeated it again further 3 months and it's come down to 57. So then we told him just to carry on with that kind of side and take it forward. But hopefully that helps to kind of give you a bit of a balance on what you should be doing. I think the really important thing that you need to remember is thinking about your different options here. So when you're looking at your glycoside, it should be short term only on that front. So short term is going to try and do it. We shouldn't ideally have people on long term because there is increased risk of failure of therapy. It's going to keep punching that pancreas to release insulin. It's going to come to a point where the pancreas can't be punched anymore. It's going to clonk out altogether. It's going to stop working. So you're going to get treatment failure with going on with it. It's there for short-term use to help to reduce down that blood sugar over short term and then add in other agents where needed. Your DPP-4s are there to nudge down your blood sugars down by 4 to 5 millimole per mole. So if they're quite frail, quite elderly, you just need to nudge it down. Absolutely fine. Your Ribelsis third line is going to be there again to go and try and balance it out on that front and to help to do what the injectables used to do and try and help in that increase in that GLP-1 naturally in the system as well. So the incretin levels to increase up your it's not natural incretin, but your analog incretins that are there from your GLP-1 receptor antagonist side. It doesn't provide the CV protection. So again, just like how Jeff had said, although now it's an option, we will need to be changing probably people across after when the injections come back in. But it's something just to bear in mind. But you always have the option of NPH insulin as well, which people aren't overly concerned about wanting to take these days, because it's an injection every day, and then that comes a lot of other complications and other issues. So
Mummy,
those,
sorry,
yes.
There's a question in the chat saying, what do you think of pioglitazone?
Pioglitazone. So pioglitazone definitely has a place on that front. It definitely has a place. I tend to use pioglitazone in my more svelte, is the way I'm going to put it. So your slightly slimmer patients who have less abdominal obesity on that front. So where I've got a patient who's severely obese on that front, so got a BMI of 35, I wouldn't be starting it because you're going to be at higher risk of pressure on the heart in itself and higher risk of that person then developing heart failure and other complications. Because of what it does, it goes in and it's great for if someone's got a fatty liver because it will clear those liver secretions out, but they'll deposit it abdominally as well. So the patient's waistline will increase on that front as well. So you've got to bear in mind risk factors. So this is only going to increase that patient's risk of CV disease higher on that front. So it's a great drug for people who are slightly on the svelte side, slightly on the thinner side on that front. Got some bad press on that front as well, but it's a great drug. It just needs to be used in the right cohort of patients. And so the younger population, generally slightly thinner patients, will actually do quite well on that medicine. So I do think it's a good drug, but is underutilized in the wrong population, if that makes sense. So we're going to go back to, she says, our mentee, which I haven't actually got yet. I'm getting there, Niche. I'm getting there. I'm trying to multitask and do too many things. Thank God it's a laptop and not something else. So we go back to our Mentimeter, she says, on that front. And I'm going to open it up. How are we doing? How was the case study? Was it okay? Do we need more? Was it just right? I tried to make it as simple as possible so that hopefully we can put what we've learned into practice, because I think that that's important. And it's okay to say if you need more information, because we can do more case studies. I have no issue doing more case studies on that front, but hopefully it was helpful on that front. I have no issues with people saying that we need to do more, because that's how I learned when I first started doing my patients, is patient cases and looking at kind of case studies and looking at patients' notes and things and having that two-way conversation. So always happy to do a case study or two on that front. Any more responses from anyone else? I'm going to put another 30 odd seconds on the timer, but in case anyone's missed it, she says. Where is my time? There it is. So give us some love. Let us know. How did you find it? Do we need more case studies? Happy to do more if you want me to. Happy to not do them if you don't want me to. But get another response. Thank you very much. Another couple of responses. I think case studies are a good shout, Tyler. I think we need to do more case studies, so we actually learn from what we're talking about. She says. All right, so I'm going to close this off in a rolling mo. Okay. And then we go to the next three kind of questions to add on to your supervision and your CPD side as well, like we normally do. So just to add into the mix on that front. So from today's presentations on that front, how do you feel about supporting patients with clinical and non-clinical areas covered on that front? So how do you feel on that front? More confident. Amazing. That's what I want to hear. Good. And that's what we want. That's the whole point of our sessions, is to give you guys that confidence, hopefully, to help. We've got confident, more confident, and clear. Good. Better, but need to improve confidence. Absolutely. And that takes time. And that's very normal for it to take time on that front. So good insight. Amazing. Just glad no one's written confused. Can you imagine? I would be a bit like, okay, we can have a chat later on that front. Confident. Resources are very helpful. Amazing. Better understanding on drug choice and confidence. Amazing. I think that's what we intend to try and get from these sessions, is that we want you guys to feel like you're more supported. So you're getting that more support. Useful and feel more confident. Amazing. Feel better. Oh, amazing. As long as you're feeling better about things, that's what we care about on that front. Last 10 seconds, guys. Feel like I'm counting down New Year's Eve. She says, okay. Next question. So after this session, what do you want to do to implement things more differently in your practice? And how or what do you need to do that going forward? Let me open turn on responses would help. So what do you think would be helpful for you guys to make sure? And it's come up on my phone, so it should come up on yours. Think of a word, think of a few words, a couple of words together. What do you think? Share what was discussed? Absolutely. Look at self-standard guidelines. Absolutely. Audit patients. Great one. Share some of the slides. Absolutely. Run a search for inlet. Absolutely. Really important. Oh, wow. Okay, fine. Loads of things. Okay, so we've had a few more. So SGLT2 audit, practice makes perfect, share with team, start a diabetic clinic. Amazing. Someone wrote, just do it. Okay, go for it. Amazing. Go for it. Absolutely. More training. Fine. Read the guidelines. Pit stop, review gliptins. Absolutely. Great ideas. I'm going to pop in a little timer. Just 30 odd seconds more so everyone can then go and just fill it in. Pop in more if you want to. A DPP4 search. Absolutely. Review. Very good. Share what was discussed. I think I've already said shadow me. Why do you want to shadow me? You don't need to shadow me. Someone says something about patients, so probably review patients. Empower patients. That's a great one. Empower patients is a great one on that front. And audit patients, I think, is a big one that I think we've got from here. So really glad to hear that you guys have hopefully found that really helpful. And then I think this is our last one. So as part of a team, how do you think you can use the knowledge from today's session to enhance safety of prescribing in this clinical area? So what do you think you can do clinically to support those patients on that front? So we've got what we're going to be doing. What are we clinically going to be doing on that front to support these patients? Is there anything like a nugget of information that you need to go and take to go and make a difference for these patients? Share the knowledge of FT. Absolutely. Absolutely. Stop GLP-1s of target. Absolutely. Because again, it's pointless person being on it if they're not responding to it because they may be one of those non-responders. Monthly MDT meetings. Great. Glycoside not a long-term therapy. Amazing. Honestly, if that's the one thing you take away for it, I'm very happy with that, honestly, because it's a huge thing. Glycoside should not be long-term, and I could bang my head against the wall for that one multiple times because it's really important that it's not a long-term therapy on that front. Monitor patients on GLP-1s and check HbA1cs and weights. Absolutely. And audit on glycoside patients. That's a great idea. I think that's something that we've probably used a bit too much of since we've had GLP-1 shortage. So I think that's a great idea on that front. And especially if someone's below 53 millimole per mole, absolutely need to be probably looking to reduce down that dose, if not stop it, because of the risk of hypos, depending on what dose they're on. So that's a great idea. And so review GLP-1s. Great. Got another 30 odd seconds for anyone who wants to get their answers in. Up titrate GLP-1s is up there as well. Query safety needle. Is it indicated? That's a great response too, actually, because I think that's really important. I have some GPs who just prescribe it for everyone on that front. And I do think to myself, really? Is that right on that front? Any more answers before we go? She says. No? Okay, fine. Well, I think that was my last slide saying thank you for participating and hopefully we see you again next month on that front. And as we've had already our concern on that front, we've already had our lovely Nisha say the next one is face-to-face. So if you haven't registered, please make sure that you register so that we can go and make sure that we are you guys are going to be coming, because otherwise we won't have space and you definitely won't have enough pizza. And I had to order it twice last time on that front. God help us. So Halima's right, with elderly or frail patients who have good HbA1c showing diabetes in remission, is there a good reason to continue metformin or any single therapy? Well, you tell me, Halima, you need to come for some education with me. So when you're looking at the evidence and the guidance on that front, when you're looking at them, when you're looking at metformin, metformin is a non-hypo-causing drug. But when you've got a patient who is at 41, it depends on what the patient wants on that front. And if they're old and frail and elderly, you want to potentially think about that risk of heart failure and CKD. So if you've got heart failure, CKD, you'd want to carry on for definite with the SGLT2 because it's going to be beneficial. So EMPA or DAPA on that front. So irrespective of HbA1c, you'd want to carry on in CKD or heart failure. So that would be irrespective because that's used in diabetics and non-diabetics for that matter. If you've got a patient who's on metformin, on the UK PDS study said even having a low dose of metformin can be cardiovascularly protective and can reduce down can improve cardiovascular outcomes. It was a very small study about 20 odd years ago though, if you think about studies comparatively, but that's why metformin is always first line these days in absolutely everything, and it always has been, because there is some data to say it can be cardiovascularly protective going forward. So for that reason, they tend to say it's better to be on a low dose than no dose if you're on a higher risk on that front. But for the SGLT2s and for metformin, I'd probably say a low dose. It's SGLT2s for those two, for CKD, heart failure, irrespective, yes. And it's going to protect the heart. Metformin, you can probably get away with stopping on that front. But yeah, that would be kind of where I go from that. All right, I'll stop. I'll get off my soapbox now. But please register for next month if you haven't. Please let us know if there's anything else that you need and if there's anything else for. And I will go and talk to Hala about us creating a WhatsApp group if that makes life